Your lungs move more than 20,000 times a day. Every breath, they glide against the chest wall, frictionless, effortless, silent. But there is a space surrounding those lungs, and sometimes that space fills with something it was never supposed to hold. This is called an empyema, pus trapped inside the chest cavity. It usually starts somewhere else, a bacterial pneumonia that doesn't fully clear, a lung abscess, sometimes a chest injury. The infection breaches the pleural space, and the body responds the way it always does. It says everything it has. The problem is that response makes everything worse. The severe inflammation triggers the body to lay down fibrin. In a confined space already full of infection, the fibrin starts building walls. And now you have a much bigger problem than you started with. The standard response makes complete sense on paper. Hit the infection with antibiotics, insert a chest tube to drain the pus out, let the lung re-expand. Except in about 1 in 3 patients, it doesn't work. The pus is too thick, the fibrin walls block the tube, the antibiotics circulating in the bloodstream can't reach the sealed pockets, the infection isn't draining, it's just sitting there, contained but very much alive. The lung is trapped, the patient is getting worse, and now you have to make a decision. The first is surgical, a procedure called VATS, video-assisted thoracoscopic surgery. Small incisions, a camera, specialized instruments. The surgeon physically breaks down every fibrin wall, clears the infected tissue, and restores the pleural space mechanically. Complete source control. The problem is solved by removing it. The second road doesn't involve an operating room at all. Instead, 2 enzymes, TPA and DNase, are injected directly through the chest tube that's already in place. TPA breaks down the fibrin walls, DNase thins the pus itself. The infection doesn't get cut out, it gets dissolved. Mechanical force versus chemical precision. One requires a surgeon, an OR, general anesthesia, and recovery time. The other requires a syringe and a protocol. Both claim to solve the same problem. So, how can we know which one works better?